a little bit longer. So the first colleague will be delivered by our colleague, by our friends who decided to come over to deliver speech. Here we're talking about microsurgical tubular decompression. What, where, and then.
Так, а где микрофон был? У нас микрофон должен... А, есть.
Thank you very much. It's a true pleasure to be here and participate in this conference. Is there a clicker to control? Thank you. Okay, so we'll start the conference off with a very small topic, and I'll share some of the experience that I have working with tubular decompression. I think it's a fact in our society that things continue to get smaller, and we see this in so many factions of our life. And that's not different for surgery, but we must remember that the goals of surgery remain the same despite whatever technique we use. So we must, first and foremost, if we're dealing with patients with spinal stenosis, decompress the nerve tissue. But we have secondary goals, which are to avoid excessive damage to surrounding tissues, reduce the blood loss of the patient, reduce pain, and hopefully facilitate a rapid recovery. And so that's where I think this type of approach has its advantages. The concept of using a tubular retractor is very simple. It's inexpensive technology that's been around for a long time, and it allows surgeons to use the instruments and the techniques that they're familiar with. Recently, there have been increased interest in the endoscopic approach, and while I think that approach has certain advantages, for stenosis, in my opinion, a tubular retractor approach is easier and makes more sense using a microscope because you have good access, you can work efficiently, and you can do the surgery in a similar time frame to what you would if you did an open procedure. So what type of cases are appropriate for this approach? Well, I would say most cases of stenosis can be managed in this way. Central stenosis, lateral stenosis, and most foraminal stenosis. But I think the one exception is a case such as this, where you have severe collapse of the disc space where the exiting root is impinged. In such a case, I think it makes more sense to try to either expand the inner body distance or to do something like a T-lift where you remove the facet, because a simple decompression may be ineffective. So I'll go through quickly the basic setup. We like to use a radiolucent table so that we can localize everything with our fluoroscopy. We start by just localizing the incision with our needle, and then through about a 20 millimeter incision, we're going to make a small soft tissue flap to create room for us to work. And we do our serial dilation, and we place our retractor. And this is the second time when we take a fluoroscopy shot to make sure that we are in the right location. There's one concept of working through a tube that's important, and that's the concept of wanding. Wanding means that you will angle the tube to get to different areas of the spinal canal and maybe different levels. So you need to be free to move the tube, and it's important that the table retractor can be held in that position. We like to roll the patient's bed away from us so that we can see across to the opposite side, and that allows us to do both sides of the decompression, as I'll show in a moment. The actual instruments that are used are very simple and familiar to every surgeon, and I'll show just some videos. This is clearing the soft tissue away. When you first come down, there's always a small cuff of muscle that has to be cleaned away so that you can see the bony landmarks before you start the procedure. So what we see here is a small section of the lamina through the 20 millimeter tube. And then when we're going to do a stenosis case, I like to start by drilling across to the opposite side. So we come under the spinous process and we aim towards the opposite side, and I'll show that here. This is a slightly edited video for time's sake, where we're drilling under the spinous process, and we see the bleeding cancellous bone, and then we see the lamina on the opposite side, which is doesn't bleed as much because it's a little bit more cortical, and then eventually we reach the opposite facet. And then once that's thin enough, you can just simply remove the medial portion of the facet using a pituitary rongeur as shown here. And then the technique is very familiar. I like to use a probe to be sure that there's no adhesions onto the nerve tissue. And then we can use a kerosene to finish up the decompression. In most cases, I have to wand the tube a little bit up and a little down to finish this, but a small amount of adjustment allows you to complete the entire procedure. When you're done with everything, it's important to use a hemostatic agent because normally we will not use a drain for these types of procedures, so we need to be sure that the bleeding is very minimal at the end of the procedure. So here we've completed the decompression, almost. A couple more bites to check and be sure. Okay, I think we're done now. And we'll use our hemostatic agent to go and obtain good hemostasis before we're done. Okay, so using this technique, I think you can obtain the same amount of decompression that you can with a traditional laminectomy technique. And I'll show this video just to illustrate some of the advantages. So we're now withdrawing the tube out of the patient, and we see the soft tissues coming back together. Here's the fascial layer, and now we're into the adipose. But the video illustrates one of the advantages. Sometimes in the United States, we have patients that are very obese, and you can see how this patient to do with a traditional technique would be an extremely big approach. But with the endoscopic technique, we can avoid the morbidity of that very large approach. So for closure, it's a standard technique. We normally will allow the patients to go home on the same day of surgery, or if they're older, maybe one night in the hospital. So in summary, I think this technique is feasible for most of spinal stenosis. I think the learning curve is fairly manageable because the general surgical techniques are similar. Our experience has been that the recovery for patients is quite rapid. And although it takes a little more time when you're first doing these surgeries, after you get used to it, I think it can even be a little bit more efficient. Thank you very much.
Спасибо большое. Thank you very much.
Thank you very much. So the speaker managed to stay within our time limits, and if you have any questions, you can address questions to Greg right now. So just think it over. If you want to, you can ask your questions later on. Greg,
do you use a microscope in your daily practice?
I use a microscope for almost every surgery that I do, with the exception of a major deformity surgery. In that situation, I don't find the microscope is helpful because the approach is very large. But for 100% of the stenosis cases, I would use a microscope. I think it really allows you to operate more carefully, and this is an advantage.
Мой вопрос, как выбрать
So a question: how can you choose the access? Should you use tubular retractors or microscope? What do you choose? For example, if there is a simple operation, for example, disc hernia, not stenosis, have disc hernia.
Disc herniation, hysterectomy or something like this. How do you choose approach? Tubular retractor or microscope?
For me, I would use a tubular retractor and a microscope for basically all of the surgeries I do up to something like a major deformity. So if I have a patient with just a small disc herniation, I would use a smaller tubular retractor, but the same basic technique that was shown for stenosis, of course, I would use that, but I would also use that for patients that have degenerative spondylolisthesis where we're going to do a fusion. I would use a similar technique, but there, of course, we're going to be usually doing a T-lift type technique for the fusion.
Okay. Дальше, да. Коллеги,
Colleagues, so I think this is one of the most relevant issues, which is how we ensure and provide for an access. So when we reach the most important structure of the vertebrum and all those nerve parts, we understand that we need performance decompression, then we need to free the spinal cords and the nerve cords from all the factors that actually affect them and cause this or that symptoms. But as for the access technique, it actually identifies what we see, that what kind of angle of attack we have there. Why do we decided to discuss this issue today? Because sometimes patients with the same diagnosis, just imagine that we have a certain picture on MRT, some clinical manifestations of the problem, and the way the patients will be operated, the place where we're going to make an incision, I mean, from which side, etc. It all depends, unfortunately, or not maybe unfortunately, depends on the clinic and hospital he or she will be taken to. And in some cases, if, for example, there are 2 or 3 departments working on this type of surgery, it's also makes a difference. It also depends on the doctor, I mean, medical specialists. Is it better or good? Maybe Andrei Anatolievich Green will extrapolate a little bit more on that, which is particularly valuable for us to hear his take on that. He knows all the techniques and he has been through all the possible stages of that sphere, and probably we should give him the microphone to go through this issue. Well, to begin this, I would like to say that when you get an experience, you become a philosopher, and then you are able to change your philosophy. And I would like to remind you that many achievements, and the one also that are stated in a kitchen, like we say, it is was initiated by men. Why, for example, because sometimes your wife forces you to wash dishes, and that is exactly how a dishwashing machine appeared. If you want to clean your clothes, that's how all other items in our household appeared because we are lazy. We are lazy. That is why we get all those gifts of our civilizations. We also modify a little bit our approaches because we are still a little bit lazy by nature. Why do new techniques appear? For example, you've seen have just tubular decompressions. You cannot do it with big instruments. You cannot use a huge drill to do that. That is why we have those new instruments, brand new front end, and the main goal is to minimize surgical intervention and also to minimize recovery time, etc. So let's take a look at these slides. On the left-hand side, you can see operation that was performed at the beginning of 2000, multi-level trauma boy, aged 18, and he decided to take his father's car, and so then he had two discs broken. This operation lasted 12 hours. Can you imagine? So you doctors had to spend 12 hours at the table where he was operated, and on the right hand side you can see operation that lasted 6 hours, and the axis was also smaller, and here we can see that muscles do not intersect, so they are taken apart.
Naturally, we get a question: in which case there will be less pain, and what kind of surgery to select? What helps us to decrease surgical aggression? These are endoscopic technologies. On the top, you can see a lady made a tattoo with a big cut, 22 centimeters, and at the back, we made the same thing. We use endoscope with exoscope, and that was possible only when we got special technique to do this, even with us. And here is the axis line at the level of it's called thoracolumbar frenectomy. So we go into the chest, cut diaphragm, and go inside the stomach, and then there is a small axis. We cut diaphragm like 1 or 2 centimeters, do whatever we need, then brought the muscles together, and that's it. So I don't have to convince you in that. These are the stages of operation. We have cut the skin and tissue, and then the surgery, and after surgery care. The access took me like 1 hour, 1 hour and a half, and the same time to fix the tissues. Now it takes 15 minutes and to finalize like 15 minutes. And these are the slides and the surgeries that can be done with this access. Of course, it's not that you have an access, let's use it everywhere. It depends on the surgery. The amount of surgery should not change. It should be whatever you need, but whatever access you need is secondary. And these surgeries can be made minimally invasive, rare access, trauma of spine. Dmitry Nikolaevich, you taught us in the 90s if a vertebra is broken, then 2 vertebrae higher, 2 vertebrae lower, and you have to fix it. What kind of access we should allow? And now we can actually decompression. We can use fixing. We fix special screws and then minimally invasiveness, and we change the body of the vertebra with the minimal access and almost painless for an ill person, for a patient. And here at the distance of 5 or 6 centimeters, this is the operation cut, and it will never hurt. These are technologies, new technologies. Now we can make open access and we can put the screws, and this will be better for the patient, correct? And this is the situation when we have to use it in a standard situation. And we cannot go after the failure, fracture of the vertebra. You see that there is compression of the bone marrow, and we didn't. What can we do with this case? And we can reach the access through the nose, and we use this and drill this using the technology, and we made a decompression, and nothing so that complicated here. Of course, we apply doctors who can make operation via nose. This is ENT doctors are surgeons also included. We drew this out, and the decompression of bone marrow is done. We could fix the neck part of the spine and then safely remove this part from the front part, the one in the fracture. So that is normal decompression, and we can see, I would like to attract your attention, you see compression on the left and on the right, couple of days after the surgery, when there is still a swollen part. So MRT in the first 2 or 3 months cannot show this decompression. It is related to hernia and other things. So that is why many people come after surgery. We made MRT, we have still the same. No, it's not like that, because after 3 or 4 months, the space is even bigger at this level. Just consider this. The fractures of vertebrae 11, 12, open fracture, minimal invasion, screws, we actually fix it through the skin. Frontal axes are very small, the cut in the neck is minimal, and all that is using modern technologies with screws and portal surgery. That is when we make a surgery on Megarel, and the axis, how many muscles are there, we should go laterally and actually devise and recruit with the tubular retractors and with the percussion. And we do change axis, moving the muscles without traumatizing them, and these will be less invasive access. And one of the options which we showed, like a surgeon who had the practice of minimal invasive surgery at one part of the spine, can use this in all the parts of spine for his surgical experience. Also transarticulatory fixing, use the C curve, so a C arc. We need expensive equipment, and it can be done in minimal invasive way. We cut the muscle, then the muscle is divided, and there is no need to traumatize. And next day the person can walk. And these, which used to happen before, it was not very fast to cure. And I don't like to work with the neck, back part of the right back of the neck, because it is very hard. It's bleeding, and on the back it's very hard. So it's a way you select. So use these technologies of minimal access and fixation, and the same for the fractures in this part of the vertebra and different kinds of fixation. What kinds of solutions? The vertebra fractures, we do it with percussion, vertebra plastics, wonderful method. We use a C-arc applied, or best of all it would be to do it in a surgery room, like with the double proaction C-arc. We make it, it's so wonderful, and during one day we can make the bill is like 60,000 and 80,000 rubles we earn. But minimal invasive technologies are normally done with the application of X-ray machines, because we need to target, we needed to reach to the point and to bring these screws with the X-ray control. These lead glasses and all the equipment weighs a lot, and the X-ray load. Have you ever thought about X-ray load on the doctor when we use these minimal invasive technologies? You see, this is the data from the USA research about the surgeons, that oncological diseases happen much more often. Just see this data, how fast it is growing. As we have less invasive technologies, then oncology level is growing. The cancer of throat happens often, more often, and we should protect eyes. And if there is a minimal invasive therapy, and if you do 3 operations per day, and or you made even more surgeries, how much radiation you'll get? So what's the solution to the we need to use navigation and robot assistance. If we remove X-ray load on the patient and on the doctor, we should think about this as well, and not only about the fact that it's all good. The robot assistant provides lots of advantages. It helps to target, and it helps to reduce load over the doctor. Navigations. Now we don't have to decide discussed, this navigation helps to go very precise. And operation tables, you see this table, minimal invasive surgery, but this table cost more than 200,000 euro. And now a question, what is minimal invasive method of treatment to select for a woman, 38 years, with a paresis in her left hand at the place with the hernia, expressed pain syndrome, and within 2 weeks after the therapy there were some x-ray done. Looks like it was easy, she felt better, but the cuts are still here. What do you suggest to do? Well, possibly, Andrei Anatolievich, at first we should ask a question. Which axis we select? Axis, yes, maybe you should, we can do it from the rear, portal axis, or from the front, stabilizing, without stabilization, artificial disc. You see how many options we have. What would you suggest? Share your opinion. Sergei Nikolaevich, what do you think? Microphone, please, because we will not hear the translation. Well, most likely this is the regular operation in this kind of pathology would be frontal axis and removal of hernia disc hernia, and introduce inter-disc cage. Well, and depending on what we are going to have with us, different methods. Evgeny Evgenyevich, and what would you do? The same frontal axis and a disc. Do you have any other options, Viktor Mikhailovich, and you? Well, that frontal axis, that is the first thing that occurs to me, frontal axis. Well, Dmitry Nikolaevich, what do you think? What have I selected? You? Well, I believe that you are making intrigue here. You want to intrigue us, because 90% of people being here would select the method that has already been offered, but it's not by chance that you are asking. Tell us. Yes, we have the same school, that's why you know what I mean. So, have a look. This is the result of the treatment after 11 months. No access at all, without surgery at all. So, you take the bread and butter from Mr. Tkachev. You take their earnings away. Well, there are some kinds of hernias that can be dissolved, and there are special methods to get rid of this intrigue. What made it possible for me to take conservative tactics? The patient came to me after 2 weeks. You might have been on vacation. Well, she felt better. Her pain was reduced. Paresis stopped growing, and she felt better. So the clinical picture was improving faster than MRT picture. The hernia is of a grape type. You see that there is lots of liquid there. It's not like with this fibrosis link. A young woman, good blood circulation. She has no problems with the blood pressure. So, and we had regression of paresis, and of course I've done an neurophysiology, and we got already re-innervation moments, and we managed to do it without surgery. This is our microsurgery. Thank you for your attention. The conclusion: you should find time to make a surgery before hernia dissolves. Thank you very much. Well, possibly you have some questions or comments, Greg?
That was a very impressive non-operative care, and I think it's exactly the right thing. My question for you is, how long is normal to wait?
Microphone. Use microphone.
Okay. Is it okay? You can hear me? Okay. My question is, how long in a normal situation would you wait if a person, of course, has no major deficits before you would decide on surgery, given the fact that we can see dramatic improvements? How long should we wait?
Ну, естественно.
Well, of course, I discuss it with the patient. I discuss the situation with the patient, and I tell you have a chances that everything will be all right without consequences. You have a chances that the hernia will be dissolved and everything will be all right. However, when this patient came to me in the first 2 days, of course I suggested surgery without thinking about it, because I don't know how it's going to develop, because after a week she can have a very bad situation, and maybe it will be pressure over arteria, and she will have neuropathic symptoms. I don't know how the process would develop, and then I will have to suggest a surgeon. But there was a kind of positive tendency, and I suggest to be conservative. Some of the patients agree, and some of the patients disagree. No, we are afraid of staying paralyzed, and they go for a surgery. So this kind of situation that we select, and then I observe the patient. As soon as you feel worse, you come to me. If there is no dynamics, so better we meet after 1 month. So, and always in contact by telephone. That's it. Thank you. Well, and I would like to add that when at the disc hernia at the lower back area, when we operate, we get oriented to the quality of life. The hernia disc at MRT is only a picture. I normally say, well, I have uneven nose. It doesn't have a regular form, and maybe I don't like it that much. But it doesn't prevent me from breathing. It doesn't spoil my quality of life. People are not running away from me. Looks like I'm not that scary. So I'm not going to make any surgery at my nose, even though ENT doctors are watching. Let me do something to you. No, thank you. No, thank you. I'm fine. And patients with disc hernia, they have an unbeautiful picture at MRT. But if they have a wonderful quality of life, they can jump, do push-ups, play football. There is no need to make a surgery. Quality of life is number one priority. But when we are speaking about neck part of the backbone, if this hernia is located at the central part and there is no additional spaces, that is a totally different story. Because if at the lower back it just hurts, neck part, it's also dangerous. That is why the tactics will be a little bit different, and possibly we should just memorize it to bring it to discussion when we discuss the problem of a neck part of the backbone. And in this case, this is lateral hernia. We could see that, and it's quite a good tactics when there are no symptoms, just to wait. Even though when I see a patient with a hernia in the neck and it is located right in the center, I tell nothing hurts right now, you have good quality of life, but you have some indications for a surgery, especially depending on lots of criteria. Well, thank you very much, and now I would like to introduce Alexander Kruchko from Novosibirsk. He is head of department which is responsible for treating of patients with backbone pathology in the Novosibirsk Institution of Traumatology and Orthopedics. And people say that Novosibirsk is a very honorable place where vertebrology was born. Such a strong Russian work. The first meeting of vertebrologists in Russia and the first associations of vertebrologists in Russia were established in Novosibirsk, and since then Alexander Vladimirovich is one of the leaders in vertebrology in Novosibirsk and in Russia overall. And I asked him to make a report on sagittal balance. Could you please tell me, in your daily practice, who used the criteria of sagittal balance to plan surgery? Please raise your hands. And who does not use? So I'm not the only one. And maybe I do not know lots about this. And once I took one book about sagittal balance, and I graduated from mathematical class, and I actually got stuck in this formula, and I asked Alexander Vladimirovich to make a report, sagittal balance for the beginners, that is for me. If you do not consider yourself a beginner or not a specialist, I suggest that you should buy a book by Alexander Vladimirovich on sagittal balance for dummies, not for dummies. And please tell me where we can buy this book. And after your report, maybe I will also be able to read this book that is not for dummies. Well, thank you, Dmitry Nikolaevich. I'm very grateful for an opportunity to participate in this event, and I would like to express gratitude to Moscow and Muscovites who welcomed me not only with good weather, but with friendliness. And now, a mathematical part for humanitarians. Sagittal balance. Something is wrong in this picture. Something is not direct. What exactly? And here, this street artist, we can see that he cannot sit properly, and there is some secret. The center of gravity is located so that the surface area should compensate for this center of gravity location, and he's staying in this position for some time, or maybe for even a couple of hours. Making the picture shots for our patients, we can see that the situation is similar to this street artist. They have a shift of center of gravity, and we do not know how to correct it for the patient to feel better. And as an example, I would like to show how before we used surgery of spine without proper knowledge. That is some simple routine situation, degenerative spondylolisthesis for vertebrae, and everything seems good, and perfect surgery, correctly installed construction, and with one small exception. What happened after 3 years, and why it actually happened? Back in 1992, Madame Duval-Beperon, a French lady, she is not a surgeon, she is a rehabilitologist, and she performed scientific research, and she was searching for some parameters in the spine which could be applied in a clinic, and she found some constants, but finally the most popular was the slope between the thigh joints and the backbone vertebra. It is not. It is perimeter. It is not good or bad. It's just like a color of an eye of a person. And the blood type, a person lives with this. It can be bigger or smaller, and for the whole life. But for some surgical movement, it is the same. It is constant. That is the only thing that you should know about sagittal balance. It's enough for dummies. We know that, and we know that the spine depends on one of the constants. And then we should make some.
Some observations in order to understand what depends on this value. This constant value calls the pelvic incidence. This is an angle that goes through these bones up to the plate S1 and line perpendicular to this plate. So then these parameters change. So the next parameter is called pelvic tilt. This is how it actually rotates. Then this next one, sacral slope, and again we can see that the pelvic floor also rotates, but here some other values are it. So they are compensatory natures. We also have geometric formulas. I promised you some geometry and math. So these are just mathematical formulas allowing us probably to do something, but they not needed them in our everyday life. So these parameters they have direct impact on the quality of life. We can measure it only with the help of our questionnaires, but we should say that all those questionnaires and the direct link between the quality of life and parameters of this sagittal balance. You can see it here. And the closer the value to the norm are, the better their life is, the less pain they have, the more distance they can walk, and so the better the quality. Here you can see some articles that confirm this statement. So in everyday practice, we can perform this calculation based on X-ray study. Of course, the first one will be the site projections to be taken into consideration. So we need to conduct the studies preferably for the whole height. And another, which is really important for our spinal surgery, is how actually this constant pelvic incidence is connected to the backbone lordosis, because this is something that we can change in an interoperational way when we stabilize vertebrarium. The most important segment for the fixation and I mean the quality of life and for sagittal balance are the two lower segments. So as a result, we can see this formula L4 and S1. The most important balance accounts for approximately 60-70% of the overall backbone lordosis. We were approached by patients with almost a straight vertebral column, and in order to properly understand what kind of angles and operations we must apply, we can use these formulas that I have just shared, and then we can plan our surgical interventions. Since the pathology was localized within L4-S1, we had some surgical intervention at the level of L4, L5. We have generating stenosis, and after the operation, only at one level we change the level a little bit, I mean of the angle, I mean the incidence, and just change the form of the vertebrae a little bit, so that it is not absolutely straight anymore. What kind of norms and pathologies do we also have? We also have a special line. It's just like the center of gravity. It is located within this area, and it goes up to the line S7. If we go through the edge bone, compensated if it goes closer to this side, and partially compensated if it goes closer to the hip joint. And when we have older patients, we can see this kind of patients, and judging from the way they walk, you can judge about the age of the person. Sometimes we have can see some old women, and they walk in a special way, so they lean a little bit forwards, and their walk really changes, and we're trying to understand how to help such people. For example, this is one of our female patients, so she could not actually walk because there have been such serious changes in the spinal column that we actually had a feeling that she was carrying something in her hands that made her lean a little bit forwards. And in this case, we wanted to change the curve of the spinal column and to change the sagittal balance, and that's the quality of life. Also, I would like to say that this parameter pelvic incidence, it can be different. But we just want to say that here we have 4 types that were also revealed by our French colleagues, and it turned out that all those diseases that appear in spinal column are also related to these parameters. For example, the first type we have disc herniation at the upper level, and type 4 we usually have spondylosis, and type 3 we usually here have stenosis, and something that we inherit from our parents, our pelvic incidence, something that we took from the nature, can also be directly linked to the diseases that we suffer in our life and that require surgical intervention. Thank you very much. Can you raise your hands if you are not surgeons or orthopedians? have nothing to do with orthopedics. So those who are not surgeons, do you have any questions? Good afternoon. A very interesting presentation. I just wanted to ask you one question. Well, it would be relevant for non-surgeons particular. I had an impression that if we look at an X-ray image of the patient and try to change sagittal balance, then the quality of life will improve, right? So it means that you use this X-ray and I mean just to make a judgment without any. Just use this X-rays to do that. I mean, not just that. We perform comprehensive treatment. We search for the reasons what leads to pains or factors that might have a negative impact on the life balance, and that is how we decide on how the sagittal balance should be changed. We want to use our surgical skills to the benefit of the patient and consider all those factors to do that. Okay, as for obstetricians and gynecologists, have you ever worked with pregnant women or after delivery of the baby? Could you just say a few words about that? Some cases we operated female patients even right after the delivery and I mean birth of the baby, and in many cases. So we should say that we achieved very good results. As for changes in the sagittal balance, since such patients are really young, I shouldn't say that there have been any such dramatic changes in the sagittal balance. And could you please say how often do you use this kind of approach? I mean, calculation every day? So all the patients who are taken to your hospital with spinal vertebral disorders, they are exposed to this analysis. Well, the point is that there is a certain deficit of inspection for patients in other cities, especially in remote corners of the country. And those patients who are taken to our hospital, we finalize all those inspections and we check them up. And sometimes, I would say even or very often, they will change their treatment plan. So this is just a routine thing that you do with every patient. Yes, exactly. As a neurologist, I actually worked with this issue and balance and use also stilometry. Do you use it just? Yes, we do use stilometry, especially during the post-operation period, and we even defended a thesis on that. We also have a report on the changes of such factors and decompression-related interventions. So I would like to just jump in and say that there are not only surgeons but also ordinary people. So we should say that all our body parts are located in front of vertebral column, and that is why our center of gravity located very close to the hip joint. And now I would like to tell you that, for example, we have a patient in the cervical vertebra, and for example, we cannot see anything on MRT. Here we have a zero center of gravity. And what if typhus? The patient has a typhus and patient leans forward, but where do they usually look? In this direction, and then they change the position of the hands, and it means that a real burden burden load goes on all their joints, and they can feel this pain in the neck. And here we have a typical situation of hyperthyroidism, and instead of the right approach, we prescribe massage, etc. But it's because our organs they instinctively make us lean forward. We need to have some kind of compensation, also using our muscles. We should do our best to prevent such situations. So if people have very good muscles and muscle framework, then they won't be coming to us so often for an operation. So when you take care of your body, it's really nice, yes, and it's absolutely important to take care of your muscles as well. But not all people suffer from this kind of deformation when they get older. There are people who can compensate for this deformation, and it does not require any surgical intervention. We usually lose this disc height in the upper part of the column, and here we have this lordosis, and that is why we tend to lean forward, and it's very difficult for us to walk. We took those patients with not just distorted sagittal balance, but with those who have relevant complaints. It means that they can walk less, they have pains, and maybe they are not as pronounced as in other situations, but they are of depressing nature, and it's very important to free patients from that kind of pains. I would like to highlight once again that we are not gonna use only X-ray approach and use X-ray grams. We must study all the complaints and then perform a certain surgical treatment. Thank you very much, Andrei Vladimirovich. So we have time for 2 more questions. We are actually running out of time. So modern medicine doesn't actually consider the position of the internal body parts, which is a part of our anatomy. In our organization, we developed special equipment that allows us to restore the position of the internal body parts and their right movement, which allows to also avoid any spasm, to improve, also to work on the atonic muscles, etc. Even after during the post-operational period, and we also can remove protrusions. So we have some publications on that matter, and they are available. Yes, we like to read this kind of literature. There is voluminous literature on that, but still I prefer traditional methods for getting new knowledge and new ideas. This kind of statements must be carefully analyzed and somehow certified. And if indeed there is something behind that, and they can be substantiated, of course it would be nice to take a look at them. We know that you are a fan of a traditional approach. That is why I saw that reaction from you. So I have a quick question. When you study sagittal balance, do you also consider prior operations on total or partial operations on hip joints? Yes, this PI index might change, especially after arthroplastic, especially dysplastic autocross, when the X of rotations is not in the right position, and in fact it is located within the soft tissue, and when the parameters of the rotation change, then we see this normalization, exactly what we have been doing. This, for example, arthritis, arthrosis that leads to hyperlordose. And when you restore this rotation axis within this hip joints, parameters go back in norm. So we get rid of lordosis and we get kyphosis in the thoracic area. So orthopedians, they always are in our way. They always do something better, and then we have to work on their sagittal balance. So we always have to fight with them. Alexander Vladimirovich, he did a very smart thing, and he decided to make a presentation about the sagittal balance in the first session instead of the second one, because he knew that I was supposed to deliver a presentation on that in the second part. And you know that even in the name of the presentation, it was clear that I will be talking about this kind of things. But those ideas were really interesting. And anyway, during the second session, all those in favor and against him will be able to discuss all those issues with him. So anyway, our next presentation will be delivered from a speaker from Kurgan, by speaker from Kurgan, direct. So here we can see director of the institute, and also he one of the leading specialists in this field of expertise. He works with spinal problems with kids and our young patients. Do we have any people working with kids? And we understand that this issue is quite relevant, but we have to understand what we're talking about.
We all understand that pain as a symptom and complex of pain symptoms is a very complicated part. It is understood in a different way. It is very wide, but children are understood in a different way as well. From the point of view of the orthopedician, a vertebrologist, or surgeon vertebrologist, a child is a person who is still growing and undergoing changes. If he is no longer growing or changes, then all the technologies applied should be totally symmetric to adults. And from the point of view of passport age, from the point of view of statistics, so healthcare organizations, this is passport age. Let us see the structure of the diseases. See, we have children with backs in pains in backs with so-called dorsopathies, and children make like 30%, 28%, and teenagers make almost 40% with some deformed dorsopathies. And there we have the syndrome of pains in the back. Let us see the cross section for our region. You see in different regions, starting from central to far eastern region, and you see the allocation. Somewhere there are quite a lot at far east, or in far east it's quite rare, and the Caucasus it's much less, and on the northwest it's quite typical. And see the allocation between children and teenagers, and it's not symmetric at all. Does it give you any idea? Let's see further on and see the regions with minimal and maximum number of deforming dorsopathies and complaints as to the back pains. And we see the most patients we have in St. Petersburg, 176 per 1,000, but there are not so many children see this allocation. And if we consider Chechnya Republic, they are not there almost. There are some surprising allocations. Let's take Ulyanovsk region, 139 and 81.7. Somebody is very carefully working with children and maybe not so active with the teenager. Why I'm saying that? We do not know how much pains in back children and teenagers have, because we basically do not understand what is deforming dorsopathy, and what kind of structure of these statistics is truly needed to arrange this or that actions or measures to work with this group, because there are 28 groups, and here we have everything. However, we have almost 1 million of years and of children and teenagers being taken into hospital, and we operate 2,000 annually with some back problems. But in order to understand all that, we can just divide the group into 3 basic groups and put 3 flags: red, yellow, and green. Well, red is the most dangerous thing, and the task of any specialist who is facing pains in the back is to understand whether a patient gets into the red group, and this is only 1%. In other words, we check 100 patients and one will have problems. Yellow isn't easy because there is kind of an amnesis. It's easier, but still there are problems. And the easiest is with an unstructured pains from the point of view that this is the main flow, and it's quite hard to deal with them, but the result is good. What is the red group? Of course, these are all dysplastic processes. First of all, we face spondylolisthesis. There are some terrible spondyloptosis, and people addressed with the back pains for a long time, but the diagnosis was wrong. And sometimes it just requires additional examination. There are different tumor problems. See this localization, night pains, typical night pains, destructive processes of a different type, infectious. Alexander Yurievich will tell you about it later. Systematic genetic diseases, osteogenesis, no trauma, just pathological fracture, pain syndrome. We have to understand with these genetic diseases a very dangerous condition. There can be small pains in the neck, but we saw some anomalies, some kind of stigmas, which help us to think about more complicated pathology, which can result not only in pains but in worse competencies. Well, when other segments take more load due to other segments being not functional, when we blocked, for instance, lots of vertebrae, and we had degenerative changes lower and upper, and rare diseases such as juvenile intervertebral disc calcification, and it is often mixed with oncological disease, and worry about this strong pains initially, and then everything is all right. However, it creates lots of worries. These are main parts of the red flag and exclude all the rest. When first of all we have gradients of pains, symptoms, ontological scoliosis with the children, strong localized pains and night pains, and also be very careful, pay attention to the children who have stigma disorders and pain syndrome in the back. As to trauma, it's quite easy. It's a rare situation from the point of view of surgery, but quite often from the point of view of addresses. Normally, small children have problems with the neck, car accident. What we do with them? If it's a minimal trauma, we do not know what to do with this. So we fix it and provide conservative treatment, but they will have short-term pains in back, 7 days maximum, and basically they feel quite okay. But we keep on doing something with them, and there are no proper proofs whether we need to fix this and how, and so on and so forth. Of course, if it is a bad injury, the problem is that sometimes we miss this window for surgical treatment, because adults operate surgeries often, and children's orthopedics quite rare. And as it is done rarely, the heavy case can be missed. So here we should address to adult orthopedics who should help to children orthopedics. And this is the situation of the most frequent pain syndrome. When just in the morning you wake up, you see the head bent, and Varvara is right here. You can see her. She's alive, everything, and healthy. This is my daughter. She also had this problem, and this is Vika, and we had to make a surgery. What is the difference? difference? The difference is at this problem with the neck, there is a very strong pain for children from 3 to 15 years. And a couple of years ago, we understood that there's arthritis, like inflammation in the area of joints. We found it with the MRT, described the situation. This is pediatric disease, which is revealed through acute pain syndrome. It can be cured just at home by staying in bed, and we still sometimes make some considerable treatment, which is wrong. Why it is so interesting? It is interesting from the point of view of economy. This kind of a million children being hospitalized, most of them will have this minimal indications. Even in Kurgan, they are very interesting. You do not do surgery. We do not have materials for that, and thus we got 25,000, 16,000, and in Kurgan, we do not take people to hospital with the syndromes. So first of all, we should remove these red flags, as the trauma can be at the background. And for MRT, we would solve this question, but not everyone have that in the hospital. We should make consensus and do not actually try to cure healthy people, and also call for adult surgeons in case of surgery. And all the rest is not structural pains, so-called. They can be anything. First of all, we should understand that we imagine that children have rare back pains, but children have often back pains. But this pain type is not structural. It's kind of tired character. Lots of pains in the back connected with the fact what kind of family you have. Psychological pains. Often children get into the pains in the back because of the psychological problems. They miss school classes. We see it with children. We cannot understand. We do not find anything, but then for some reason they feel better when the family problem is solved. It's well known that if in the family there is somebody who keeps on complaining over back pains, granny, father, mother, the child is more likely to complain about the back pain. And no matter what you use to treat them, sometimes placebo effect also works well. You will cure them. That is why always a conservative treatment is efficient here, and any directions of road medicine. That actually is confirmed by lots of researchers, and the most fresh ones, well, emergency department with acute pains in back. Only 2-3% with the true problems. Others are basically healthy. Well, we truly like to speak about the fact that there should be a correct hygiene, correct load without heavy backpacks, but there is a fresh investigation, analysis of 69 researchers on how heavy should be the back pain, the backpack, whether it can create back pains, and they haven't found any connection or dependency. But there is also such a notion as a vertebra cautious, and it should be comprised of some experience, understanding of something to be wrong, and some ideas that there cannot be only very popular diseases such as scoliosis, but also something else. Thank you. Thank you very much. Wonderful, wonderful. And the question, Alexander Vladimirovich, systematic therapy, sweets can be related to this therapy as a painkiller. How can I address you? If you take this sweet carefully, cut it as a beautiful ball, put it in a beautiful box, and make correct conversation about the fact that this is a new pill that will help, sometimes it will help. But if a child from 3 years old has a pain, you give him a sweet, and then it's all right, no? Well, placebo, yeah, placebo. Any other questions? It's very interesting to work with children. Good afternoon. I'm a pediatrician, and I have noticed, I have been working for a long time, and actually every third to be exact, with hypoxic problem at the cervical vertebral and central nervous system, and with the disorders in central vertebra. And I would like to ask a question. What is the role played with the shaft and a kind of shunt collar to prevent such serious pathologies of cervical vertebra? And this is a very good question. And once this was developed in Kazan, what is the detail? If we speak about the neck part and all the rest, here I can use support of Mr. Kritko. Unfortunately, there is no literature which would prove that there is connection between damages during delivery and then pain syndrome and osteochondrosis and whatever we were doing. We were doing X-ray shots and saw some instabilities, found minimal anomalies connected to the delivery, and then tried to scale it to the problem of osteochondrosis with adults. Nothing worked, so it did not match. And for me, it's a very important thing. If it's not matching, then I believe there is a mistake. So I doubt that we have some pathogenetic chain of transition of one disease into another one. As to Shan's collar, and just getting into detail, it's a convenient thing because it's quite easy to prescribe and it doesn't have any consequences. Looks for wearing, like you keep on wearing it. It's not to make a surgery. It's not like manual therapy or special exercises prescription. But if this problem with the neck, I do not recommend to use Shan's collar because a child can get cured faster, and otherwise it will be unreasonable to work the Shan's collar. If you understand that it is easier for the patient, maybe because of tiredness, pains, because he keeps on sitting at the books and while preparing making some tests or working at home for a long time, somebody use a collar and select symptomatic treatment, and they feel better and they think that's a good method because it trains teenagers, and from the point of view of small children, it's totally useless. Another question, and if we have time, could you please tell, have you checked whether there is a connection of development of scoliosis with inner uterus trauma and delivery traumas with further hypertones with the babies and so on and so forth? Well, we had such research. There were lots of attempts in Russia, and we cannot create pathogenetic chain, how they are interrelated, how to bring that together. We find lots of different indices, like when you read Ratner, there we have a clear picture of that. And when I read Ratner, I loved him, honestly. I just adored him. You read and find answers to all the questions. But when you start practical work and you see lots of patients and you do not find a true connection, you cannot collect pathogenesis, you cannot explain, we do not know what is idiopathic scoliosis, and even these findings related to other diseases, what was meant by the authors, how to connect this, and how it is related to a lot of distortion of spinal column. And in Novosibirsk and in the world, it is quite well proven how to bring it all together. Good explanation. It's quite a beautiful legend, but that is very weak from pathogenetic point of view. Thank you. But the question was good, as this is a popular theme. Thank you very much. Thank you. Dmitry Nikolaevich will announce the next speaker, and the last speaker at our session will speculate about hernia treatment of spinal discs. And Alexander Tkachev, who established a clinic in Volgograd on conservative treatment of patients with spinal disc hernia, well, is kind of a person who is trying to deprive all the surgeons sitting here of their normal work. That is why we had to keep track of him, invite from his place from Volgograd to Moscow, and now I'm going to listen to him, and then I will ask you to take decision what are we going to do with him. Close the doors for him not to run away. We have reliable people at the doors, and they will block the doors, and we will see. Then we will calmly operate. Please be careful with your report. Well, I have a badge, Association of Neurosurgeons, and Mr. Konovalov gave me, and he said this is amulet that can protect me and leave this room once. Now we admit it. Okay, so there was a hernia in the cervical vertebra, and asked what kind of operational access they would select. Actually, I raised the hand because hernia, as to the signal characteristics, had a very good chance to be removed, and actually we know that it truly happened there, and I was asked to make the discussion more sharp. I hope to stay alive after this discussion, but I believe that this should be the true science, because only in live discussion, only in interesting argument, we can create a truth. What is the most often question asked by a patient with neurologist or a neurosurgeon when he is asked about diagnosis of spinal disc hernia and he's recommended a surgery? Of course, the patient looks for alternatives and asks whether it is possible, if possible, how, what should be done for that, to make some, to take some pills, to make some exercises, and so on and so forth. And today I'll try to answer this question not only from scientific but also from practical point of view, how it is possible. Today we are going to speak about resorption of spinal disc hernia. That is decrease of its size in natural conditions, and I represent Epifanov, and unfortunately the other person sits here and he can also answer your questions. So we're doing research about this phenomenon from 2012. It's already 8 years, and we have reached quite good results. Once it started, but now our team is growing. We have Professor Kanalbi, who is famous for knowing bacterial component in spinal disc diseases, and we were joined by Garrett Parada from Russian University Chicago, and he asked to say hi to Anderson because they know each other. This is my second protection, so I hope to stay alive. And this year we have finalized the prospect toward research of 101 patients with a spinal disc herniation who were recommended to make surgery and who actually got cured without surgery. This is classical scheme of a metro line of pains in the spine, and I would like to see the way the patient goes through from. We have some form, and under the influence of internal or external factors which can result in degeneration and spinal hernia. He reached the part neurology, and there are only two scenarios. He is cured, he got back to a normal condition, and the second option, he was treated and it was not better. Neurologist got scared of the size of the hernia, and then they moved to neurosurgery. Then there are only two options of solving this problem: make a surgery and then get to normal condition, or make a surgery. The efficiency of this surgery proved to be below expectations, and he either got stuck at the station or bought a constant ticket and keeps on moving between the neurology and neurosurgery, which works all over the world, but it does not work well. It is proven by statistics.
International statistics, which say that starting from 90s up to 2019, spinal pain is ranked as #1, and there have been a 50% increase. 20% of acute pain becomes chronic despite all those achievements in neurosurgical, for example, surgery. We do not really well understand this pathology yet. I have always been disappointed by neurologists' opportunities and capacity in terms of treating such diseases because we are quite limited in terms of instruments and diagnosis tools. We do not really always understand how to eliminate this pain, but at the same time I always envied neurosurgeons because they always want to remove the cause of the pain, which is disc. And here we have another metro line, a green line, that united two aims of here we need to remove not just pain but also disc hernia. And to do that, we need to better understand the processes which lead to the decrease of pain. And now patients can get to us from both stations. In case some neurosurgeons in Moscow sent their patient to us for consultation. In 2018, we ask our patients how neurosurgeons and neurologists say their patients during the primary visit whether there is an alternative way to minimize their hernia, to remove it. And only just a small amount of them could say that hernia could shrink in size. There are two reasons to that. They might know that, but they don't know how to use it in their clinical practice, and sometimes they keep silence on purpose. But I think that the answer is the first two answers. What about resorption? So there is meta-analysis and a lot of case studies, and one of them showed that 60% of hernia are able to for resorptions. Yes, we have them, but if you look at the meta-analysis, we can see that there are not so many patients. There are no study of the type of hernia and other factors. Some were scanned using MRT or CT, and sometimes the treatment lasted from 4 months to 2 years. I mean, the whole diagnosis and analysis. But we know, based on the studies that have already been done, that there is a direct link of clinical improvements which is related to absorption. So here we can see very interesting information in the reports that includes all the factors that can facilitate this process. And here we can see information about spontaneous hernia inflammation. We see that resorption happens because of inflammation. What is inflammation? This is a reaction of congenital immune systems, and usually it is a response to any tissue damage. And the aim of the inflammation is the healing process or recovery to the state of homeostasis. So you can see this balance. On one hand, it leads to healing, but on the other hand, excessive inflammation can damage tissue even more. And so far, science hasn't found an answer to that. I think that you can see resorption of a hernia before and after, but in fact, the resorption process has certain stages. This is the same patient within a period of 3 months, 7 MRT, and any process of resorption can be segregated into a number of stages. The very first stage, this is a stage of active inflammation. So when we have all those cytokines where patients feel pain, and this is the red arrow, and here is a particularly high risk of for the patients to be taken to the operation table. Macrophages M1, these are the cells that participate in this process. They are responsible for gastritis, so they eat cells of interdisc hernia, and then the active phase goes to the proliferation state. Macrophages M2, they get polarized, and so they convert into M2 format. They suppress inflammation, and then we go to the remodeling stage. It hasn't yet been really studied by the science science, and in some literature you can see that it lasts up to 1 year. Anyway, we see that pain level in these patients, if we look at the visual scale, fell down during even as early as during the fourth emergence. Some characteristics here are still modified, and we see such patients and patients with just such a clinical situations without any indications for operation. They still suggest that hernia should be removed, if even though the clinical site does not tell us so. I decided to take my statistics from Volgograd, so starting from September to January 2020, we had 85 patients where surgical hernia removal was suggested, and 2 patients only were only operated. Other were either in resorptions. I mean, there it wasn't performed. Here we have resorptions that happened within 2 months, 3 months, 5 months. This is hernia in the cervical spine. So here resorption within 6 months. What does resorption depend on? Usually it happened depended on the age. Yes, younger the patients they demonstrate these resorptions. It also depends on the size and type of hernia. Then also we should say that the bigger the hernia, the smaller the chance for it to grow in size. But at the same time, it takes more time. It depends on the time when actually a hernia appears. Maybe patients have already visited a big number of neurologists and other specialists after appearance of this hernia. The more complicated patients are those who were given some corticosteroids, agents of prolonged effect, but here it's other prolongs, or we can see no resorptions at all, and so then they are taken for operation anyway. Then other pathologists and patients of the doctor and patient. These are the main factors that affect it. What's our conclusions? Well, inevitably, we should say that we need some additional studies, but resorptions could become another instrument to control efficiency of conservative therapy. Resorptions of this kind of hernia is an alternative to the operation, and the goal is the same, to remove disc hernia, but it will never substitute operation. There are cases when we immediately send patients for an operation. Sometimes we don't understand why resorption doesn't happen at all within a period of 2 or 3 months. And we have the same clinical picture. And of course, we need to have some indications for operations during disc hernia and more vast use of resorption term, both amongst neurosurgeons and neurologists in practice. We also need some randomized studies in order to assess source impact of different factors on the resorptions, both pharmaceutical and physiotherapeutical. Well, there is a lot of work to do, and hernia resorptions require some additional studies. We need to understand its clinical meaning, some other factors, so we can come up with a more detailed treatment plan. I would like to say that this hernia, well, it's not that much of a disaster. We need to get together with the surgeons in order to understand who can be operated and who should be exposed to conservative treatment. I cannot help but make a few comments. Well, any study can turn out to be a failure if you don't select the right pivotal points. For example, I'm a neurosurgeon. I think that you have picked the wrong points, I mean reference. Right now we have different approaches in private clinics and in different situations, especially when it comes to the indications for the operations, which cannot be used here as a reference point. Sometimes they in private hospitals select a disc and perform an operation, even though there is no need to do that. And when we ask them why do they do it, because it's just business is business. Or, for example, when we have hernia and we want to remove pain, we can, take a lot of alcohol, drugs, narcotics, etc., and there will be no pain. But of course, you understand that. Of course, we need to also eliminate the reason of pain. What is the worst thing could happen if we don't do anything about that, because your feet will be looking downwards in 5 years, for example, and they say, oh, I don't care, okay, I will just it's fine for me, and a lot of other situations. So we need to be very careful with all those indications that make us take patients for an operations. So it takes collaboration. Yes, some criteria which could allow us to take a decision. Sometimes we might have a huge hernia, but it might have no symptoms. And sometimes we also talk about two different things. Pain and spinal pain, and also hernia, and sometimes they are not interlinked at all. And hernia, anyway, this is just something that can be generated and can be triggered by some other diseases. And I would like to remind you that we also needed to protect our vertebral column with the help of muscles and remember of our muscles. Tell me, please, have you ever studied and do you have any long-term results, 3 or 5 years? We are now finalizing our work, and sometimes we can even see some regeneration. We are analyzing our data. Okay, and we also analyze anti-inflammatory cytokines and other try to link it with some absorption studies. Okay, if we talk about 3-year periods, how many patients were sent for surgical treatment? What's period of time? I mean, while your center was operating. If we talk about 2019, then I would say that approximately 12 people were sent for that. Of course, we always have certain criteria. We do not accept everyone. We work as experts, as a team, and take joint decisions. So Alexei Mikhailovich, in his presentations, he started to make reference to some expert, Russian experts, foreign experts, and before we let him go, we would like to address several questions to him, and then I will give the floor to Alexander Vladimirovich. I have a very simple question. Are there and have you found in the literature, or do you have a plan to come up with a certain criteria, X-ray, criteria based on MRT, come up with a certain criteria that could show you that this disc hernia, for example, have a chance to be exposed to a conservative treatment? Are there any criteria, for example, biomechanical criteria or any other criteria except for age? Yes, of course, we understand that this young patient, this is a more simple situation. So we are surgeons, when we see a big hernia, we see a patient, they have pain, but we say stop. Right now we are gonna cure this pain symptoms, so we have things to do that, but based on this criteria, you still have a chance. No, we haven't yet applied this approach in practice, so it means you take everyone and wait. It won't. So let's just wait, and if it doesn't disappear, then I will call someone, right? Not exactly. Right now we are collecting data, a lot of data, in order to analyze all that. So we can also use artificial intelligence for some additional analysis. So you wanted to some kind of have the following approach. Let's just stop all those activities, and well, you actually showed that slide, and we saw there's something about the United States, and I think someone through here will also could follow you. Well, if he gets paralyzed, of course. But still, when we see, for example, if absorption happens and if there is a recurrence, for example, don't you think that after that it's a little bit too late to operate, or would it be difficult to have any surgical treatment? You see, that is our vertebrology is not in the last position because of such doctors. So what do I mean to say? If we try to delay it, have you ever had the situation in sport? You get a yellow card if you wait for too long. No, we haven't had such cases. So okay, maybe 1 or 2%. We just really ran out of time. Who wants to be within that 1% where they failed? Well, you know, I have the following question. In fact, this is a multifaceted problem. There is a very popular study they have shared, but we have different approaches to this problem. We also have different other factors, for example, whether pain is severe or not, and many other things that need to be considered to decide on whether the patient should be exposed to conservative treatment or surgical treatment. And what do you mean to say when you say that hernia might disappear within a period of 4 years? Do you know what it's like to live 4 years with the pain? Because it could also be found in people who live an active life. They are going for sports, etc. That's what we're talking about. We talk about patients who are really scared, afraid, and they don't want to be overexposed to risks. But another point that I wanted to say is the so-called depressive syndrome triggered by pain, because any pain syndromes after 4 or 6 weeks of treatment require this depressant to be prescribed for the patients, because patients after such an intervention they might really fall into depression, and we do something about that, and we have a chance to help some patients and say that we can do that without any treatment. And at the same time, if you do it, then you should pay attention to these factors. Well, I don't know. As for hernia, well, we discussed a lot of things, but we ran out of time, unfortunately. But I hope that during our second session we will be able to talk about this question and to address your questions to our speakers later. But my question is, what are the ways to come up with some criteria or predictors that could help us to understand whether hernia will disappear or not? And we will start our second session later on. So our second session starts at. You can find it in our leaflet. See you in half an hour.
40 минут, да? Или через полчаса?